Welcome. I am Roberta Gualtierotti from the Angelo Bianchi Bonomi Hemophilia and Thrombosis Center in Milan. And today, with Dr. Jacopo Acquati Lozej, we will discuss the non-surgical management of hemophilic arthropathy. Starting from the state of art, we will discuss a clinical case report and the future perspectives in this field. So at first, we will discuss the non-surgical interventions that are currently available to manage hemophilic arthropathy. Over the last decades, we witnessed a very important evolution in hemophilia care with the introduction of recombinant factor replacement, the no-replacement factors, up to the gene-based therapy that include also gene editing. And this has led to a paradigm shift from tackling survival to the management of quality of life and the prevention of disability whenever possible. Hemophilic arthropathy is one of the most frequent complications in hemophilia, and it is very important to understand that the single bleeding can lead to irreversible cartilage damage, and the recurrent hemarthrosis may lead to synovial hyperplasia, which further damages the joint and predisposes to further joint bleeding. So it is very important to tackle this repeated bleeding with adequate prophylaxis, because hemophilic arthropathy, if not treated, may be characterized by chronic joint pain, reduced range of motion, decreased function, and overall a disease burden with direct and indirect costs with the early prosthetic surgery. So the main objectives of non-surgical optimization of joint health are the reduction of bleeding events, pain management, the reduction of synovial hyperplasia and synovitis to reduce further bleeding, and the management of osteochondral damage, which is irreversible. Of course, physiotherapy and rehabilitation for restoring function and maintenance of muscular tone are very important, but are not the objective of this presentation. Patients treated with adequate prophylaxis may still have bleeding in their joints. And over the years, we understood that 1% of trough level may not be enough because patients may still have a progression in their hemophilic arthropathy. So the current trough levels of factor VIII recommended are 3 to 5%. However, there is evidence, recent evidence, that even a factor VIII trough level of 15% may not be enough to prevent arthropathy, in particular based on the lifestyle, joint status of patients. So it is very important to personalize the prophylaxis and to gather evidence regarding the best trough level for each patient. Ultrasound, musculoskeletal ultrasound, is a very important tool to study joint health in patients with hemophilia. And we have evidence that subclinical synovitis can be observed in up to 40% of patients, and up to 20% have an active profile, which is defined by this group as the presence of a power Doppler signal. And so it means that there is inflammation inside the joint. There is some recent evidence that an intensified prophylaxis with a higher trough level, around 10%, could reduce or prevent the progression of hypertrophic synovium. However, we need more evidence to understand the cost-effectiveness of this approach, particularly in low-resource countries. On the other hand, synovitis predicts the risk of spontaneous bleeding, and as we said, because iron is toxic for cartilage, but is also able to induce inflammation inside the synovial membrane, which is the layer inside the joint capsule. And this thickening may also be characterized by angiogenesis. And so this predisposes the same joint to recurrent bleeding. So in our group recently described how synovitis may predict the risk of spontaneous bleeding even in the presence of an optimal hemostatic control with non-factor replacement treatment. And this is due to local factors. So the presence of angiogenesis and inflammation in hypertrophic synovium may predispose patients to bleed despite correct optimal hemostatic control. Pain management is an important chapter in the management of patients with haemophilic arthropathy. As you can see from the image, acetaminophen or paracetamol are the first step in adults and children with pain. And cyclooxygenase 2 selective inhibitors are also very important, particularly when there is inflammation inside the joint or after joint bleeding. And when this is not enough, we can access the opioids. And we must remember that many persons with hemophilia are currently on chronic opioid treatment. And the recommended dosage of tramadol shouldn't exceed 400 milligrams per day. As for the cyclooxygenase 2 selective inhibitors, it is important to remember that 60 milligrams of etoricoxib could be enough, and the shortest time possible of treatment should be the aim of the treatment. When this is not enough, intra-articular injection with corticosteroids could be evaluated case by case, and they are not recommended in children and in patients with a very early arthropathy because there is some evidence that corticosteroids may accelerate cartilage damage. So how to tackle pain? When there is acute pain, first of all, we need to rule out bleeding, and bleeding must be managed by hematologists with the factor replacement. And pain is a very important, also a very important objective in the treatment of acute pain, of course, because it is very important to restore function as soon as possible, so that physiotherapy can be started and the range of motion is restored. If there is no response to painkillers, as we said, we can evaluate case by case intra-articular injections of steroids. As for arthrocentesis, there is evidence that there is not enough evidence to show that it is effective in every case. So the current recommendations are to have arthrocentesis after 72 hours of treatment with factor replacement with no results. And in this case, it is also very important for the diagnosis, the differential diagnosis, for example, of septic arthritis or other conditions. When pain is chronic, of course, we use the same oral pain killers, but we need to evaluate if there is synovitis with recurrent bleeding. Chemical or radioisotope synoviotesis may reduce the risk of bleeding. And when this is not enough, embolization with angiographic procedures may be effective. And if all these procedures are not effective, we must ask the surgeon to reevaluate the patient for example, surgical synovectomy. When osteochondral damage is already present, we may evaluate intra-articular injections with hyaluronic acid, with or without steroids, platelet-rich plasma, but for these treatments, we have limited evidence regarding the long-term effectiveness. We have some data for short-term effectiveness on symptom relief. And the optimization of joint health envisages all these steps. So when there is joint bleeding, joint aspiration must be evaluated, as we said, after 72 hours. And factor replacement must be administered to the patient. The RICE, so rest, ice, compression, elevation, is effective as well. Pain management is very important, and physiotherapy can be started as soon as bleeding and pain are controlled. As for synovitis with recurrent bleeding, as we said, chemical or radioactive synoviotesis and angiographic embolization are options. A higher trough level must be evaluated for cost effectiveness in the future, in particular in low-resource countries. When there is a cartilage degeneration, intra-articular platelet-rich plasma or hyaluronic acid may be considered, and physical treatment for restoring of function is also very important. So it is important to consider all these aspects in a multidisciplinary team as a consequence in this comprehensive care setting. Oral supplements are often asked for from parents or from the patients themselves But there is very limited evidence on this option, and the only evidence available is for high dosage of glucosamine sulfate and chondroitin sulfate, but not all scientific societies in osteoarthritis recommend them, as you can see from the right table in the slide. So what we need to consider is that it is not possible to regrow the hyaline cartilage. To date, there is no evidence. So the only evidence we have is from preclinical models and in vitro studies, or very few patients with low evidence studies. So the goal to date is to prevent recurrent hemarthrosis with an adequate primary prophylaxis, which must be started as soon as possible. So the first question is, what is the recommended management of acute joint pain in haemophilic arthropathy? If joint bleeding is confirmed, immediate physiotherapy. If joint bleeding is confirmed, factor replacement, rest, ice compression, elevation, and pain management. Immediate start of NSAIDs and oral supplements of glucosamine and chondroitin in any case. Arthrocentesis followed by intraarticular corticosteroid injection in any case. So the correct answer is if joint bleeding is confirmed, factor replacement, RICE, and pain management.